Again. Sorry about that. Welcome to tonight's webinar, and this is our mission to help people better understand how their minds and bodies work. And of course, tonight we'll be talking about how the female reproductive cycle works and the things that can go wrong. The second part of our mission really is to help people find the best modalities, be they nutritional supplementation, medical attention, fitness experts, what to look for, what questions to ask of your chiropractor, your naturopath, your doctor. Help you be an intelligent participant in the health and care of your body. And with these two, hopefully we will be able to set people on the right track. And we are so grateful to have our presenter today to come talk about a much needed but very little understood topic called intentional sexuality. And I'll wait for Sherry to hand over to her while I dig up her bio to set it up. Okay, in just a minute, I will be reading. Okay, Vicki Latham graduated in 1992 from Oklahoma University Health Science Center in Oklahoma City, Oklahoma. As a board-certified physician assistant, she has worked at several health centers and women's clinics, including a 10-year tenure serving as the women's health practitioner at the Oklahoma State University Health Center, where she gained valuable experience attending to the unique medical needs and challenges of female college students. She currently works with Associates of Medicine, headed by Dr. John Williams. In addition to her medical pursuits, she is a teacher of dance and exercise and was a professional ballet dancer, not belly, but ballet dancer in New York City many years ago. She is a teacher at heart and loves to educate people on how to make good choices that will move them step by step closer to a healthier lifestyle and a longer and more prosperous life. She also works with the Wayora International Corporation, educating people all over the world on the benefits of detoxification and nutritional supplementation. By the way, I am very impressed with Wayora and the products and the technology that they are bringing to the world. Very impressed. And you need to ask Vicki about what they do. Now, her focus is on pregnant and breastfeeding mothers, helping the next generation of children to become healthier and more toxin-free than their parents. She has 5 grandchildren, with one coming on the way, and her exercise of choice is ballet, and she loves to work in the garden and kayak. Her retirement goal is to continue to do international mission work and, of course, continue to teach. So, Vicki, thank you so much again for joining us on this webinar, and we are looking forward to what you have to offer by way of education.
Well, thanks, David. And you too, Sherry. It's always a challenge for those of us that are scientifically oriented to sometimes engage all this technology. But I think I'm going to give it a go tonight, and I really appreciate everyone for being here and listening to my presentation. I'm glad to share this information that surprisingly I find that most people really don't understand about women particularly, but if there's any men out there, I don't want you to be intimidated. I think you'll learn some things about the women in your life as well that can be very useful to you. And but I find that it's really surprising how many women really have very little understanding about what is really going on in their body with their cycles, and they have various questions that I hope I'm going to be able to answer tonight. I've given this presentation for sororities, for civic groups, for churches, and when we get to the end, there will be my contact information, and you're certainly welcome to contact me, and I would be more than happy to come to your organization and speak and present this information. I particularly love to speak with young people because that's when they're making these very important decisions about what they intend regarding their sexuality. And that's the whole point of intentional sexuality, is to not just have sex, but to have sex on purpose. And to make wise decisions, because as David said earlier, knowledge is power. Knowledge abates fear. It allows people to have greater choices so that they can move down the path to their greater purpose. So that's what I want to go over tonight. And I'm going to start with the physiology lesson. I'll hope this won't be too in-depth for you, but we're going to start with just some basic physiology, because when I mention these words, I want us all to know the same thing. This is a picture of course, a female body, and I hope you can see my cursor. And going from the front to the back, we have here the pubic bone, followed by the bladder, followed further behind by the uterus and the vagina, then the bowel, and then your sacrum and coccyx. Now over here shows how when the uterus is full of a baby, how your bladder becomes a teeny weeny little bladder. I always say if you want to know where the bathroom is anywhere you go, find a pregnant woman, because they always know where the bathroom is. But we're going to focus primarily on a uterus that's intentionally not pregnant, but we're going to learn more about how that happens. But we are going to talk about the uterus and ovaries, tubes, and vagina. And that's going to be the areas we're going to talk about. The vagina, of course, here, the uterus, the tubes, which are sometimes called the uterine tube, or sometimes they're called the fallopian tube, but I'm just going to call them the tubes, and the ovaries. And of course, you have a match set. Now, ovulation is the time when the ova or the egg, sometimes I might say ova and sometimes I might say egg, but they mean exactly the same thing, is released from the ovary. And the question that most people ask is, when is the most opportunistic time of my cycle for getting pregnant? I mean, when are my most fertile days? When is it most likely I could get pregnant? And when do I ovulate? And I have talked to women who have their doctorates in equine reproduction, and I ask them, do you know when you ovulate? And they have no clue. Most people have no idea. And it's very, very important to know this. So by the end of this talk, you are going to know that. Now, here's some physiology, and the main thing I want you to see about this busy slide is that you have hormones, and hormones are chemical messengers in the body that come from a gland. And you have a gland here in your brain that's called the pituitary gland. It's one of your master glands, and it controls many, many activities in the body, one of the most important being your fertility cycle. And it emits some, where's my cursor here? And it emits two hormones called luteinizing hormone and follicular stimulating hormone. That's this, LH and FSH. And it has an effect on your ovary, which produces two predominant hormones, estrogen and progesterone. It also produces testosterone. Yes, women do have testosterone. In fact, when you have too much, you can have something called polycystic ovarian syndrome. And you can have male pattern hair issues like growing a beard or having hair places you wish you didn't have them. And sometimes that's just that you have hairy women in your family, and it's familial, particularly people who live from places like Italy and some of the Middle Eastern countries. They just naturally have more women have more hair, but in general, women who have hair that's in a pattern like a man usually is having too much testosterone. But we're not going to talk about testosterone tonight, because while it's important and very critical for our sexual desire, it's not that important for our hormonal cycle, and that's what we're really talking, and it really has some to do with ovulation, but it's not as critically important that you understand that as the estrogen and the progesterone. But the whole reason I want you to see this slide is because I want you to see that there is a connection between your brain and your body, because that is very important. So here is a slide of what happens to your cycle during the month of the rise in estrogen and the rises in progesterone. Now, what happens with your estrogen is that it rises and then it has an abrupt fall. And when it does that, it triggers ovulation. Ovulation occurs right after that fall in hormones. For this presentation, at the beginning here, we're going to talk about what happens when things go right. The normal cycle is usually considered about a 28-day cycle. It can be connected with the moon at times. People talk about it being a 28-day lunar cycle. And in fact, women who live where they are out under the moonlight all the time and not subject to lights from just street lights and phosphorescent lights, when they just go to bed when the sun goes down and get up when the sun goes up, and they don't live with any artificial light, tend to ovulate with the cycle of the moon. So that's just kind of a little interesting thing that happens. But for us in modern America, our hormones are not usually connected with a lunar cycle. I mean, as far as really connected with the moon itself. But a 28-day cycle means that you will then ovulate around the mid-cycle, around the 14th day. And if it was just that easy, we'd be done with the lecture. But it's really quite complicated compared to what I just said. But we'll move on here. Now, the next hormone that's important is progesterone. Progesterone is low until you ovulate. And when you ovulate, then it has a sharp rise that lasts for about 10 days. And then if you're not pregnant, it falls off. So what is happening during the time in response to estrogen is that the estrogen is causing the ovary to mature. It's what's called the dominant follicle. You have little egg sacs inside your ovary. You have all of the eggs that you are going to have when you're born, and you actually are born with about 1 million of these little follicles, these little egg sacs. When you reach about 100, you're usually in menopause. There's a normal progression of loss of these follicles, and then you also lose 1 egg a month to ovulation. And so out of all these multiple little follicles that are sitting dormant, just all waiting for their turn to mature, you have one that becomes what we call the dominant follicle, and it ovulates. And it does that in response to ovarian hormones that come from stimulation from the brain. It also develops a lining inside, a nice, rich, vascular lining, so that if you conceive a baby, that it has this nice, rich, oxygenized place to grow and develop. So during this first part of the cycle, you're maturing the egg and you're developing this endometrial lining, it's called. We're just going to call it the lining. Now, when the ova, or the egg, ovulates from the ovary, it's picked up by little finger-like projections on the end of the tube that are called fimbriae. And they're kind of like a catcher in a baseball game. It's like the ovary tosses out the ball and the fimbriae catches it. And then the egg travels down the tube and finally enters the uterus. Now, it takes about 36 to 48 hours to travel down the tube to the uterus. And conception must occur in the tube during this 48-hour trip. And we'll talk more about that later. Now, while all of this has been happening with the estrogen, now the place where this dominant follicle I told you about, that dominant follicle turns into something called the corpus luteum. And corpus luteum produces the hormone progesterone. That is why you don't have much progesterone, is because you don't have a corpus luteum. But as soon as you have ovulated, then you begin to have the rise of progesterone coming from the corpus luteum. The most common reason, besides someone being pregnant, the most common reason that you skip your menstrual cycle is you just plain didn't ovulate that month. Because in order to ovulate, to have a period, you have to have ovulated, you have to form the corpus luteum, and you have to have this withdrawal of the progesterone hormone to trigger your body to have a period. So if you don't get your period most of the time, it's just because you didn't ovulate. So going over this again, real briefly, you have the estrogen that grows the endometrium and matures the dominant follicle, and you have the progesterone, which comes and forms the corpus luteum and produces progesterone. And this progesterone has two primary effects. One is it inhibits the endometrium. So back here, where before you had the effects of the estrogen that was producing this lining, now you have the effects of the progesterone that inhibit the lining. It's kind of like the estrogen says, I need to make a nice lining for the baby. And the progesterone says, okay, but don't make it too big, because if you make it too big, there won't be a place for the baby. So it inhibits the growth of the endometrium. As we get older, one of the first things that happens as we begin to reach menopause is that we begin to lose the effectiveness of the corpus luteum. So instead of the corpus luteum lasting this nice long 10 days, it can vary. It can last only a few days. So it rises, and so it doesn't inhibit the lining very much. So sometimes you can get all kinds of very irregular bleeding, very heavy bleeding. Women are sometimes go, gosh, I haven't had bleeding like this since I was a teenager. And all of a sudden, I'm 40 years old and I'm bleeding like a teenager. Well, that's because you don't have the progesterone inhibiting that lining appropriately, and the withdrawal of the progesterone is happening way too early in the cycle, and so you end up having perhaps multiple cycles. So some months you might not ovulate at all, and you might go a few months without a cycle, and then you, because you've had all that time, the growth of the endometrium, because of the dominance of all that estrogen, not inhibited by the progesterone, when you do get a period, it can be really bad. So that's something that happens that we all have to look forward to as we get older. But we're back to our normal program here, and so you have the estrogen maturing the egg, creating the endometrium, and you have the progesterone inhibiting the endometrium, and also it is a powerful inhibitor of something called prostaglandin. And I'm not going to talk about that right now, but I am going to talk about that when I get to dysmenorrhea or painful periods, and it will be important then. Now, I hope everybody's with me. Everybody understands now what those hormones are doing in our body. Now, this is important. Remember, we're talking now about a 28-day cycle. The time from ovulation to the time when your period comes is very predictable. That's because the corpus luteum simply begins to produce progesterone, and then it falls off, and that loss of the progesterone brings on your cycle. But the time from when you get your period here on the very first day of your cycle to the time when you ovulate can vary. So therefore, when do you ovulate? Well, you take the day that you get your period and you minus that by the normal 14 days, and that will tell you when ovulation is. So it's a pretty easy little math formula. Ovulation equals your menstrual period minus 14 days. So you have your menstrual period minus 14 days, and that will tell you when your period came. So that means that it's really easy to know when you ovulated when you look back. However, it's impossible to know when you're going to ovulate by looking forward. And the reason that this can vary so much is because of that brain connection. Remember, we talked about how the brain has an effect on the functioning of your estrogen. Well, that's what makes us women. We are very, very fickle because we have very fickle hormones. Our estrogen levels, and of course men don't have much estrogen, so they're a little more stable emotionally. But we have lots of estrogen, and it can be affected because of the brain connection with all kinds of things. Your estrogen levels can be changed and affected by travel, illness, medications, changing altitude. If you sleep outside on a camping trip because you get more moon and sun time, it can be affected by weight gain, weight loss. It can be affected by virtually any type of emotional stress. So because of all of these things, our hormones are make us very, very unpredictable. It makes us also lots more interesting and lots more fun. So, I'm going to give you a few examples here. So if you have a 28-day cycle, 28 minus 14 is 14. So therefore, you ovulate on day 14. Remember I told you that once you ovulate, the egg is traveling down the tube for 36 to 48 hours? Well, that means that on day 14 and 15, while the egg's traveling down the tube, that is when you actually can get pregnant. And that's actually the only time you can get pregnant. If the egg passes down the tube and enters the uterus, it can't get pregnant there. There are things that happen in the tube that don't happen in the uterus that are necessary in order for your body, for you to get pregnant. And I'm going to talk about those next. But let's say that you have a 24-day cycle, and this month you had a very short cycle. Well, that means you ovulated on day 10, because 24 minus 14 is 10. So your days when you are at risk of getting pregnant would be day 11 the day 10 and day 11. Let's say that you have a really long cycle, and it's 34 days. That means that you ovulated on day 20, and you were at risk of pregnancy day 20 and through 21. So basically, from day 10 to day 20, that's when you usually can get pregnant. Your chances after about the 22nd day of your cycle of getting pregnant are very low, because an egg that waits that late in the cycle to mature often is not going to be a viable egg. However, I can tell you about my friend who called me up and she said, "Vicki, it's day 22 of my cycle, and you know I want to get pregnant, and I actually think I'm ovulating. What should I do?" I said, "Call your husband to come home. What else?" So you can have that happen really, really late in your cycle, or you can have it happen early in your cycle. And here is the most important part of this whole thing, besides what is going on with the egg, is what is happening with the sperm. Because while we only have 2 days where we actually can get pregnant, we actually are at risk of pregnancy for 7 to 9 days. And here's why. Sperm can live for 5 to 7 days. They enter, of course, through the vagina and go through the uterus, and some of them swim down the right side of the tube, and some of them swim down the wrong side of the tube. The right side of the tube meaning not the right and the left, but the one where the egg has ovulated. And when they enter the tube, the sperm experience something called capitation. It's like the top of the head of the sperm comes off, and little enzymes are released. And those enzymes allow the sperm to approach the outer shell. There's actually an outer shell to the egg, and it attaches to the wall of the egg, and these little enzymes begin this process of trying to break through. It's called a zona pellucida, and break through this outer shell. Except one really smart sperm, very smartest of all the sperm, kind of hangs back. And as soon as the other sperm have broken through the shell, the smartest of all sperm shoot through and are able to combine their genetic material from their open hat with the genetic material of the woman so that a baby can be produced. I kind of think of it like football. It's like you got your front line that are all there holding back and doing their job, and then you got the quarterback who's hanging back, that as soon as they create an open in the line, the quarterback shoots through and makes a touchdown. And that's kind of what happens. And luckily that is the smartest sperm of all, so that does help us all progress genetically. So now here we have an example again of our 28-day cycle. So you ovulate on day 14. Ovulation is your menstrual period minus 14 days. So here we are on day 14. But remember, sperm can live for 5 days, so we have to go back 5 days. 1, 2, 3, 4, 5. So that means if you have intercourse and sperm are deposited where they can get to that egg on day 9, then they will stay swimming in the tube, and as soon as you ovulate, they score the touchdown. Same thing on day 24. 24 minus 14, ovulation on day 10. So you have to go back 5 days, 1, 2, 3, 4, 5. So if you have sex here on day 5, the sperm can live at least 5 days. Some can live as long as 7, but for sure 5 until you ovulate. And in fact, the days before, the 2 days before you ovulate are the best time to get pregnant because the sperm have plenty of time to swim up here and swim down the tube to get capitated so that they have their enzymes ready to do the job, and so they're ready to create a new little human. Now, you might say, well, wait a minute, day 5, I'm usually on my period on day 5, and I thought you couldn't get pregnant on your period. Yes, you can. If you ovulate early enough, then you can get pregnant. So now here's an example of what happened with my friend. She was on her day cycle, and you go back day 15 through 21. So basically you are at risk from day 5 of your cycle to day 22 of your cycle. And that's when things are normal. So you actually can ovulate any time. So therefore, if we go back to our little formula here, how helpful is it to know when you ovulate? In preventing pregnancy. Not any good at all. Therefore, you need to start thinking about being very intentional about the choices that you make, about being sexually active, and planning when you're wanting to get pregnant. Because if you're not doing anything to prevent pregnancy from occurring, if you have sperm and you have an egg, you're going to be likely to make a baby. And you really cannot predict when it's going to happen. Now, if pregnancy does occur, instead of the hormones dropping off like they did before, what will happen is that corpus luteum will turn into a cyst that will continue to produce hormones for about till about the 12th week of pregnancy, when the placenta takes over the control hormonally of the pregnancy. But until then, the corpus luteum, and they can get quite large, producing those hormones. You know, sometimes people say, well, I have an ovarian cyst. Well, every month, everyone has a cyst. Everyone has a corpus luteum. Sometimes it's called the functional cyst. And everyone who ovulates has one every single month. That's different than when people say, I had a ruptured ovarian cyst, or I have cysts on my ovaries. That's a much more complicated issue. But sometimes the corpus luteum, you're not pregnant and it doesn't disintegrate the way it should. And then sometimes it can rupture and bleed and cause a lot of problems for people. But it's still, this is a little bit different than people who have cysts on their ovaries, and that's a whole gynecology lecture and not one on fertility awareness. So, so if pregnancy occurs, the corpus luteum continues to produce hormones, and both hormones become elevated. Now, one of the things I want you to really, really notice, when your estrogen is high and your progesterone is low, you have not ovulated yet. So you're pre-ovulatory. When your progesterone is high and your estrogen is lower and falling, you've ovulated. But when both estrogen and progesterone are elevated, that means you're pregnant. And when both drop, you have a withdrawal of the hormones, and that withdrawal causes you to lose the lining, and you then have your period. Now, what controls whether or not that corpus luteum continues to make hormones or it falls off and your period comes? it's actually under control of the baby. When a newly conceived embryo passes through the tube and enters into the uterus and implants in the side in that nice rich endometrial lining, it begins to produce a hormone called HCG, human chorionic gonadotropin, called HCG. And when you go to the store and you buy a pregnancy test and you urinate on the little strip that turns colors, what that's doing is measuring HCG, which comes out in your urine, usually an adequate amounts within 10 days of conception of the baby. So right away, you are able to have levels of HCG that are high enough to be able to test for pregnancy. And that HCG is kind of like a phone call to the corpus luteum saying, hi, this is the baby here. I'm here. Do not disintegrate. Do not go away. Do not drop the hormones. I'm here. And so then the corpus luteum just continues to produce those hormones that maintain the pregnancy. But if the corpus luteum does not get a call, because you did not conceive a baby and there is no HCG, then since it doesn't get the phone call from the HCG hormone, then there's no reason to keep the corpus luteum. So it disintegrates, and that drop of hormones then destabilizes the endometrial lining, because obviously you don't need the lining because there's no baby that needs it. And so then your body sheds it. So your period is your body's way of telling you, yes, 14 days ago you did ovulate, but you didn't get pregnant from that ovulation. Therefore, you don't need this lining that we made for the baby because there isn't one. So we're just going to get rid of it, and next month I'll come again and you can try to make a baby again. So that's what your menstrual cycle is telling you every month. Now, sometimes when we have those periods where we're getting rid of that lining that we don't need, we have what's called dysmenorrhea. And that means that your periods are very painful, lots of cramping. Now, some people call it, there's primary, and it's very common in your first few years after this very strange word, which is called menarche. And that just means that's when your period begins. And it's very common because hormones are very irregular and all kinds of things are happening in your body when you're first beginning your cycle, and it's very common for periods to be very painful with a lot of cramping. Sometimes, though, secondarily, you can have this as a result of different kinds of malfunctioning within the hormones or different diseases of the pelvic organs that you can have this, like infection or polycystic ovarian syndrome or other various problems. Now, when it's really severe, we call this premenstrual syndrome. And it is mediated by prostaglandin. Remember, I told you that that was something that was inhibited by progesterone, and that you would remember that. Well, the effects of prostaglandin in the body is to create inflammation, pain, and this inflammation of prostaglandins is a good thing when it is in your stomach. And then your stomach prostaglandins are called P1. And P1 creates an inflammatory condition that protects your stomach lining from the acidity of your stomach. But P2 can cause inflammation and pain in our joints and also in the uterus. And in the uterus, it causes not just inflammation and pain, but also cramping, bloating, irritability, and water retention. Now, Prostaglandin is a powerful inhibitor of P2, and estrogen also has a very stabilizing effect on serotonin. So serotonin affects our mood. So here we are, we get towards the end of our cycle, and we're having this drop in estrogen and this drop in progesterone. So at this time also, you begin to lose your inhibition to that P2. So if you have nice, healthy progesterone at this time in the cycle, and you don't have excessive amounts of P2, then you're going to be one of those lucky people who doesn't have a lot of pain with their cycles. But if you have inadequate amounts of progesterone and excessive amounts of P2, then it can make for really, really painful periods. Now, you've heard of non-steroidal anti-inflammatory drugs. Those are things like Motrin, Aleve, Pamprin, the things that you go out and buy. Those are things that block P2. Now, the problem is they also block P1. And by reducing some of that stomach inflammation, it can leave your stomach vulnerable to being affected by that acid in your stomach, and you can end up sometimes, if you take a lot of non-steroidal anti-inflammatories, you can end up with an ulcer in your stomach. So it is important that you don't take them on a regular basis, but only when you need them, and that when you do take them, you take them with some food so that that will reduce, the acid has something to eat besides your stomach lining. And the other thing is that P2 will be then inhibited by the NSAID in your uterus, and will help to block some of these inflammation, pain, cramping, bloating, irritability, and water retention issues. But what you need to do is you don't wait until you've got your period and you've got all of these problems. What you want to do is you want to start your NSAID back when the big problems are getting ready to begin, when you're losing your progesterone in a significant way, which remember is a potent inhibitor of P2. You want to start taking your NSAID about 4 days before you expect your period. So around the 25th, 26th day of your cycle, you might want to start taking a non-steroidal anti-inflammatory like Aleve or Motrin or something like that. And what that is going to do is it's going to reduce the amount of P2 that you're going to have when your period comes, and it's going to reduce a lot of those side effects. Now, some other things that are really good, believe it or not, and this is one of the reasons you crave dark chocolate. Two things are going on. One is that chocolate has a powerful effect on increasing serotonin, and serotonin in our brain is our happiness chemical, makes us feel good. Low serotonin also makes us have more cravings, makes us more anxious, and higher serotonin makes us happier and feel more satisfied and more focused. So by eating dark chocolate at the end of your cycle, that really helps to increase serotonin. And so that takes care of some of the moodiness symptoms, but also the dark chocolate can have an effect on the prostaglandins as well. So dark chocolate has multiple benefits. So yes, you have permission to eat some chocolate around the time of your period. You can call it your medicine. It's okay. And the dark chocolate that I recommend is one called Chava chocolate. It's a 70% dark chocolate, has a more enhanced effect on serotonin. And you can get that by going to the website chachava.com, chachava.com. Another thing that has a powerful effect on reducing, getting the cramps, is exercise. If you will increase the amount of exercise you do, it has a powerful effect on helping to inhibit P2, and it also increases serotonin. It also increases something called endorphins, which help your body to deal with pain. So exercise is also really, really helpful. So if you can do these three things, take the NSAIDs a few days in advance, eat some dark chocolate, healthy dark chocolate, and exercise, your dysmenorrhea will probably be much, much better. Now, we're going to talk about contraception. We've already shown how it is extremely difficult to know exactly when you're ovulating and to predict that. And because you have this 7 to 9 day window when you're actually at risk of pregnancy, if you do not intend to get pregnant right now, if that's not in your plans for right now, then you're going to want to use something like a form of contraception. Now, there's natural family planning, and this is based on knowing this fertility awareness. And you can go and learn and take classes, and you can learn about other signs that you have, such as changes in your cervical mucus, dilation of the opening of the cervix, temperature changes that happen that can predict ovulation. But sometimes those changes don't occur in time to stop those long-living sperm from happening, because they can happen just a couple of days before you ovulate, and so you may have already had intercourse thinking that you were safe. So while natural family planning in context of a couple that are really watching their cycles, and a woman who has a very, very predictable cycle can be extremely effective, it's not always something that can work for everyone. And then, in addition to these natural things, we have artificial contraception, which works with the hormonal changes. Some that happen without any hormones involved would be diaphragms and condoms. Those that are what we call combined hormonal contraceptives, where you have both estrogen and a progestin, not progesterone, but a chemical that mimics the effects of progesterone, which are called progestins, are mixed in pills that you take orally. There is a ring called the Nuva ring, which you can insert vaginally, and then the hormonal contraceptive is released from the ring and absorbed through the vaginal wall, and makes the hormonal changes. And patches that you can wear on your skin, which transdermally will have a hormonal effect. There are also contraceptives that use only a progestin, but in my experience, they have a lot more side effects, and so I usually recommend the combined hormonal contraceptives that contain both the estrogen and the progestin. And then you have intrauterine contraceptive devices, such as they call IUDs, where they insert something inside the uterus itself. Some of them have some hormones with them that they secrete as well, and some don't, and they just create a change in the pH and a disruptive environment in the lining, and a low-grade infection in the uterus that are not very conducive to healthy conception. But some women really like these methods, and they are extremely effective. All of these methods, when used properly, are extremely effective. So now I'm going to show you how they actually work. Remember back here in our little picture where it talks about how if you get pregnant, you have an elevation in your estrogen and progesterone. Well, what happens at that time is that when you have an elevation in estrogen and progesterone, your body then is pregnant. Therefore, you obviously don't need to get pregnant again. So your body then stops ovulating. And it stops ovulating because of this ratio. Remember the ratio I talked about? When estrogen's high and progesterone's low, you're pre-ovulatory. When progesterone is high and estrogen is lower, you're post-ovulatory. If you're not pregnant, the hormones drop. If you are pregnant, the hormones elevate. All we do with combined hormonal contraceptives is from day one of your cycle, you take something that has about the same amount of hormones as you normally would have, but it changes the ratio of hormones to the ratio of pregnancy, with both estrogen and progestin elevated. Because you do that, your body thinks you're pregnant. Therefore, you don't ovulate. Therefore, there is no egg in the tube. If there is no egg in the tube, if there are sperm in the tube, they're just all dressed up and ready to go, and their date never shows up. They're all ready to score the touchdown, but there is no football. So and then what you do is you take the hormones for a certain number of days, and then there are placebo pills, or you simply have a hormonal-free time. You remove the ring, or you take off the patch, or you don't take the pill. And you do that for a short time, usually 4 to 7 days maximum, and this drops the hormones down, and that loss of hormones, again, triggers your body to have a period. Usually your period is very light because you had progesterone on board. So you've had your uterus saying, I want to make a lining. You've got the progesterone saying, no, you can't. I want to. No, you can't. They're having this little hormonal battle in there in your uterus, and so you end up with a very, very small lining because you have a very small lining and you've had the progestin on board all month long. Remember how that has that inhibiting effect on P2? So when it's time for your period, you don't have much of a chance for the P2 to surge, and so therefore you usually either completely eliminate or greatly eliminate any dysmenorrhea or painful periods. So many women who aren't even sexually active, but who have terrible dysmenorrhea, terrible pain with their periods, will use birth control for that purpose. So basically what's happening is you're taking these contraceptives that are telling your body, you're pregnant, don't ovulate, no you're not, have a period. You're pregnant, don't ovulate, no you're not, have a period. And so we're just kind of fooling Mother Nature, but we're doing it with the same hormone ratios in the same way that nature does it as well. Because as soon as you have the baby, then your body doesn't any longer have those ratio of hormones happening, so therefore you begin to ovulate again, and then you can get pregnant again. And that's what happens. Now I want to mention one other very popular method of birth control. However, it's extraordinarily ineffective. And this is one of the most common ones that I see and gets a lot of people in trouble, and it's called withdrawal. And for some reason, men tend to have kind of an ego thing about this, that they think that they can control their seminal fluid, and because they can control when they ejaculate or release the sperm. Now, the normal sperm count for their seminal fluid, what we call the normal ejaculate, contains just a few milliliters of fluid. but there are 20 to 150 million sperm per milliliter. There's a lot of football players here going on. And every man, when he has an erection and is ready to ejaculate, has pre-seminal fluid, sometimes called pre-cum, and it contains about 500,000 sperm per droplet. And most men pass 2 to 3 droplets before they ejaculate. So even though they withdraw and pull out when it's time to ejaculate, they, instead of leaving maybe 80 million sperm, they would leave 2 million sperm. So how effective is that? Especially when you remember it only takes a small team and 1 quarterback to score the touchdown. So with typical use, there's about 35 pregnancies for every 100 people who use this method. It's very ineffective. So I hope that you'll remember that all men dribble before they shoot. This is a normal physiological event and has nothing to do with their egos or their ability to be in control. And I hope no one listening to this talk will ever use withdrawal as a birth control method and think that it's going to be effective, because it is not. Now, another thing that a lot of people need to remember when they're being intentional about the sexual choices that they make is sexually transmitted diseases. I'm not going to go into this in depth, but I want to mention this because it is very important in helping you make a decision about what you're doing when you're having choosing to be sexually active. I've already talked about the risks that you take with pregnancy, and now I'm going to talk about the risks that you take with sexually transmitted diseases. Of course, an STD, or sometimes they're called STIs, or sexually transmitted infections, is a bacterial viral infection. It also can be a parasite, and that can be transmitted through a sexual contact. It can be through genital to genital or just through skin contact. It can be vaginal, oral, or anal. These are the most common infections that women have. Various kinds of vaginitis, bacterial vaginosis, and cervicitis. Now, these are not necessarily sexually transmitted, but can be connected to a change in the pH, the acid-base balance of the vagina, and a change in the normal healthy bacteria that should be present. Molluscum contagiosum is a common virus that creates little bumps on your skin, sometimes hundreds and hundreds of them in the genital area, and they do spontaneously go away. Then you can get yeast infections, although they're not also always sexually transmitted. They can be, but they're not usually. Usually they're, again, because of some kind of change in the normal balance of bacteria or the normal pH or acid-base balance of the vagina. But the next ones are usually sexually transmitted. Salpingitis is infection in the tube, usually caused, we can also call that pelvic inflammatory disease, and it's usually caused by gonorrhea or chlamydia, although sometimes it can be caused by certain bowel bacteria. And then there's human papillomavirus, which is the cause of warts, or when the warts are really large and grouped together, it can be called condyloma. And this can be passed through just skin-to-skin contact. You do not have to have intercourse to get HPV in the genital area. And then the final one is HSV, herpes simplex virus. It can be type 1 or type 2. Type 1 is usually oral, and type 2 is usually genital, but not always because of oral sex. They can be passed back and forth from one place to the other. Now, vaginitis, bacterial vaginosis and cervicitis can almost always be cured with antibiotics. Molluscum, you just have to wait for time to pass and they will spontaneously resolve. Yeast infections, of course, can be usually taken care of with an antifungal. Salpingitis, oh, and I just realized I left trichomonas off there. Trichomonas is a little amoeba-like animal, little parasite that can live in the vagina, and it can be treated with antibiotics. Salpingitis, gonorrhea, and chlamydia can be treated with antibiotics, and it's very important that it is treated. One of the things about chlamydia is that most of the time when people are diagnosed with it, they have no idea that they have it. Most people have no symptoms, and it can last in the body for years and years. So it's very important that every sexual partner that you have, that you are checked for chlamydia and gonorrhea, because you do not want to get pelvic inflammatory disease. About 1/3 of the time, women who actually progress from just having infection to actually having an active infection where you get really sick, high fever, lots of pain. About 1/3 of those will have a compromise to their fertility. They may be infertile, they may have scarring in their tubes, they may never be able to conceive. So it's very important that chlamydia is taken care of and discovered. That really should be a part of your annual exam every year when you go in if you've had a new sexual partner. But these two, HPV, while usually your body will form an antibody against it, and eventually you will not be contagious, you will always have HPV. And then herpes simplex virus, that's what we call the gift that keeps on giving, because herpes reoccurs with painful ulcers. You've probably seen cold sores where people have it. That's herpes simplex type 1. And it's very rare that you are contagious with herpes type 1 unless you're actually having symptoms. You're actually symptomatic. You've got cold sores on your lip. But herpes type 2 is much different. It's much more difficult thing to deal with. And herpes type 2, you can be asymptomatic, have no symptoms whatsoever, and still be shedding the virus 20% of the time. So a person who has type 2 genital herpes may not even know they have it, and certainly may have no idea that they're contagious and spreading it. So 1 out of 5 days, 20% of the time, they can be shedding the virus with no symptoms whatsoever. And that's why we're having such an epidemic of HSV. Now it's as much as 1 in every 3 sexually active people who've had more than one sexual partner. About 1/3 of them now have herpes simplex type 2. Now, I mentioned before about some of those things that can cause you to get a bacterial infection, and that it is related to the vaginal pH and the balance of normal bacteria. We have a wonderful bacteria that live in our vagina called the Lactobacillus species. Usually it's Lactobacillus genesii, and they're different from Lactobacillus acidophilus, which you get when you eat yogurt. That usually is a healthy part of the bowel bacteria, and that's a type of Lactobacillus, but it's kind of like dogs. One's golden retrievers and one's bulldogs. Well, so there's different kinds of species of the Lactobacillus, and in the vagina you have this one kind that have wonderful symbiotic properties that really help keep you healthy. One is that they produce lactic acid. So they keep the vagina its normal pH of 4. That is very, very acidic. The pH of vinegar is about 3.5. So you can think of how acidic that is. Well, that's how acidic your vagina is, and that's the kind of acidic condition these lactobacillus like to live in. Other bacteria and yeast like a pH of around 5 to 6. So the more alkaline, the higher the pH, the more likely you're going to get a growth of bacteria in your vagina or a growth of yeast in the vagina. They also, these lactobacillus, produce hydrogen peroxide, which kill off other bacteria in the vagina, and they also like to destroy yeast. So I like to say that your lactobacillus are like your little oven cleaners, and your vagina can be kept healthy if you have the right cleaners in there doing their job. Now, when you take an antibiotic, sometimes you not only kill off the strep for your strep throat or the bacteria that you're in for your sinus infection, but those antibiotics can also kill off the lactobacillus temporarily in the vagina. Because they do, yeast and other bacteria don't have anything competing against them, and so because that, some of the other bacteria can take over, and that's why women often get a yeast infection after they take an antibiotic. So you can easily treat the yeast infection. There are medications that do an excellent job of that, and then the lactobacillus can return. And anything that helps to increase the pH, the acid, the acidity, or decrease the pH and cause the vagina to be more acid is going to keep the vagina healthier. Now, seminal fluid has a pH of 7.9 to 8. So when you have intercourse, this changes temporarily the acid-base balance of the vagina. Luckily, if you have a healthy balance of lactobacillus, the lactobacillus just go, oh wow, it got really alkaline in here, and the lactobacillus then produce lots and lots of lactic acid, and within a matter of a few hours after you have sex, your pH of your vagina is back down to normal. But if you take an antibiotic, or you've killed off the lactobacillus temporarily, or you're having an overgrowth of yeast or bacteria, then those bacteria and yeast are real happy about you having sex because they've created an environment that's much happier for them. So that's one of the things that can happen. So a healthy bacterial flora is really the key to a healthy vagina. And so I think that's something that's really important for women to realize. So if you are worried about that you're having any kind of sexually transmitted disease, these are the kinds of things you want to be looking out for. Any kind of pain, obviously, in the pelvic area, or bleeding that's not usual for you, any kind of sores, bumps, or blisters, pain when you urinate, sore throat, fever, or fatigue, which, of course, lots of things give you sore throat, fever, and fatigue that have nothing to do with being sexually transmitted. Now, how to protect yourself. So this is really how to be intentional about your sexuality. You want to talk to your partner about their sexual history and about any drug use, because I didn't really mention HIV, but it is, of course, sexually transmitted through blood or semen, and knowing a person's history can be very, very helpful. If you don't feel comfortable talking about their sexual history, then I question your comfort with being sexual with that person. You're sharing something incredibly intimate with that person, and you should be on a close enough basis to talk about their sexual history and intimate enough to ask those questions as well. You want to, of course, look for sores, bumps, and blisters, but remember, you can be shedding the HSV, the herpes virus, 20% of the time with no symptoms whatsoever. You can use a condom. A condom is very helpful for preventing HIV, but it is not very helpful for at all for herpes or for HPV, because those are skin viruses and they're passed from skin to skin, and they may not be on the area, on the penis that's covered with the condom. So that condoms really are a very, very little benefit for that. Condoms are fairly effective for helping with other STDs that are less common, like syphilis, and fairly good at helping with gonorrhea and chlamydia, but not always. The important thing is that if you are sexually active, that you get tested for STDs regularly, and don't ignore any symptoms that you have. And also make sure that the treatment that you give, that you follow those instructions exactly. I can't tell you how many women who have been halfway through their treatment for their STD and then they go out and have sex again, and with the same partner that gave it to them in the first place, and now we got to start all over again with their treatment. It's very important that you follow your instructions exactly. But if you don't want to be worrying about having any risk at all about getting a sexually transmitted disease, this is the way you do it. And this is a quote from the Center for Disease Control, and it's my favorite. You need to be an unaffected partner in a mutually monogamous relationship with an uninfected partner. Basically, you want to be somebody who doesn't have any STDs, who's faithful to a person who doesn't have any STDs. And then you don't have to worry about this. And one of the best ways I know to do that is just to wait till have sex until you're married. Wait until both of you, and I'm not just speaking to the women, I'm speaking to the men. And guys want to know how to increase the women who want to be with them. Well, let me tell you, wait to have sex until you're married, because all the women who are very wise, who understand and have intentions about what they're going to do with their sexuality, are looking to find a man who wants to wait also. So here is why I think it's best to wait. Number one, it's the best sex. Physically, mentally, emotionally, and spiritually. Many studies have shown that couples who wait to have sex have the lowest divorce rates and have sex more often. It is much more satisfying, and that kind of intimacy is really best shared with a person in which you have a committed relationship. It is the very safest. You are uninfected partners in a mutually monogamous relationship. And because of that commitment to one another, you can make your sexual decisions together, things like when you want to have children, and cooperation with your sexuality is going to be much easier because of that sexual commitment. And then you have the support of your extended families too. When you're always having to sneak off and not let anybody know, your friends or family, that you're being sexually active, that's not very conducive to, it's conducive to a lot of excitement, but it's not necessarily conducive to making love. And the other thing is that when you have sex, it bonds you together forever. This is something that a lot of people don't know and are not aware of. Remember back in the very beginning when I was talking about the brain connection? Well, there are two other hormones that I didn't talk about that come from the pituitary gland. One is called prolactin, and the other is called oxytocin. Whenever a woman has a baby and she sees her baby for the first time, and she holds her baby and her baby breastfeeds, her body releases a hormone, a powerful hormone, which gives you a sense of well-being and calmness called oxytocin. Also, when you have an orgasm, you have an increase in oxytocin. In fact, oxytocin is the chemical that absolutely has to be present in order for an orgasm to even occur in both men and women. So you have oxytocin that happens at the time that you connect sexually. That oxytocin increases prolactin, just like when a mother nurses her baby or even holds her baby, that she gets that release of oxytocin. It then triggers her pituitary gland to release another hormone called prolactin. What prolactin does is causes us to bond with the person we're with. It causes a mother to love her baby and want to protect her baby and to be with her baby and to make sure that it is not harmed in any way. And that's what happens when you have oxytocin trigger prolactin in you. You become protective and bonded, and you love that other person, and they give you a feeling that you just don't get any other way because you have been connected with the oxytocin prolactin connection. Now, women have fairly high levels of oxytocin, even just normal, just walking around. We have oxytocin. It's one of the things that makes us women. Again, it's one of the things that make us have more intimate relationships with our friends, our girlfriends, and we connect with people right away, and it's easier for us to become intimate with people on an emotional level. It's because of our higher levels of oxytocin that then produce prolactin and tend to help us to bond with our friends and other people. Men, on the other hand, have extremely have low levels of oxytocin, but they have also almost no prolactin except at one time, and that is when they have an orgasm. This causes them to raise their oxytocin and to raise their prolactin. So this makes a man bonded to you. And so when you have this oxytocin prolactin connection happen, for a woman, even without intercourse, a woman can get that connection. But when a man has sex with a woman, then he becomes much, much more bonded to her. So you want to always remember that having sex not only spiritually and mentally and physically bonds you together, but it also hormonally bonds you together. So the point of my lecture is to help you to see that you need to be intentional about your sexual decisions, that the decisions that you make really matter, that it's extremely difficult. If you're not wanting to have children, it's extremely difficult to prevent that if you're not going to use some form of contraception to keep that from happening, because ovulation is menstrual period minus 14 days. You can always look back from your period and see when you ovulated, but you can't look forward and you can't know when for sure that that is going to happen. And since you can't predict it, then you need to be very intentional about what you're doing about being sexual. I suggest, and then you can't protect yourself from most sexually transmitted illnesses either. So I suggest that you ask yourself these questions. And I suggest that you journal this, that you get yourself a little book, like a diary, and you begin to think about what you want to do about your sexual choices. It's very, very difficult when you're in the heat of passion to stop and say, Now, what was it that I wanted to do about my sexuality? No, at that point, your hormones and your physical desires have taken over, and they are making that decision for you. But your mind can be more powerful than your body, and you can make a decision in advance what your sexual intentions are going to be. And so these are some questions that I suggest you answer and you put down in your journal. One is that if I have sex, will I be able to live with this decision for the rest of my life? Because some of these sexually transmitted diseases are something you'll never get rid of. And a baby, when you get pregnant and you become a mom, that's a big, big lifetime commitment. It's a wonderful, joyful, precious, incredible commitment and experience. But it will change you for the rest of your life. The next thing is to ask, is this person really worth the risk that I'm taking? The next is to decide, what are my personal values and my moral beliefs about my sexual choices? And if I make this decision, is it going to violate those personal values and beliefs? And finally, if I'm sexually active now, is this going to be inconsistent with my goals, my purposes? Is this really, really what I intended to do? So this is the point of intentional sexuality, is for you to have the awareness and the knowledge to give you the power to make better choices, to make wise decisions, to understand the risks that you're taking, and to, in advance, make a decision about what your personal values, beliefs, goals are, so that you can have sex on purpose, not unintentionally, where you may get an unintended pregnancy or an unintended STD, but to have sex on purpose. So that's my talk. If you want to contact me with any questions, you can call me at my email or contact me at my email, toxinclear@gmail. My phone number is 405-614-0079. And I have a website that I'm actually in the process of creating. It is not up yet, but it will be up by the first week of January, called Intentional Sexuality. I started it about a year ago and I never finished it, but I own the domain name, and I've got it about 70% finished. So I'm going to have it finished by the first week of January. I'm going to have an article in Thrive OK magazine, which is an excellent online publication, and you can also find it around town at your local health food store or whatever. The website for that is www.thriveok.com. Has wonderful articles on health and well-being, and in the January issue I did an article on intentional sexuality, and on that, and so I will have my website up before the magazine comes out the first week of January. So you'll be able to use that intentionalsexuality.com website at that time to contact me, to blog with me, to ask your sexual questions. So, David, that's the end of my presentation. Do we have any anybody that has any questions? Are you there? Are you there, David? Well, I guess David went to sleep. I hope I didn't put the rest of you asleep. I hope you all, if you have any messages, you can type a message. There's a place there on your screen where you can type a message to me if you have any questions that you'd like to ask me. Well, I'm not being able to get a hold of David, so I guess we'll just close out the presentation. I really thank you for attending. And like I said, if you want to contact me, you can do so at toxinclear@gmail.com or call me at 405-614-0079.
Well, Vicki, this has been fantastic. Such a wealth of information. Oh my goodness. I know people will really, really have people they have that would love to share this presentation with. As a matter of fact, I have Elaine saying this is one of the best webinars. Thank you.
Well, good. I'm glad.
Some other great jobs as well. Other great thank yous as well. Okay, we have a few questions. Are you still up for some questions?
I am.
Okay.
I am.
All right. Now you talked about there being enough good bacteria and fewer bad bacteria. Can you repopulate the good bacteria in the vagina?
Absolutely, you can. In the old days, people used to douche. And the purpose of douching was they would take vinegar and water and they would rinse the vagina out. The problem with that was that while the vinegar was a good idea and it did change the pH, the douching activity itself was very bad because it washed out all the good guys with the bad guys.
Mm.
So now they've created one, it's called FemPH, is one that I prescribe. Also, there are some ones that you can just purchase at a pharmacy if you'll go and ask your pharmacist, because sometimes they are kept behind the cabinet. Some require a prescription, some don't. I don't know why they aren't really medicine. They're just pH balancing gels. And you insert them in your vagina. I usually recommend that women use them right after their period because blood has a pH of about 7.3, and so those days that you're on your period, you are altering the pH of your vagina. So I usually recommend right after you finish your period to insert some of this gel. Just one night usually is enough, and that will quickly convert the pH back to its normal acidic pH of 4 so that the lactobacillus can recover, recolonize, and basically take over the neighborhood, which is what you want them to do. So you can ask at the pharmacy or you can ask your physician if he would prescribe some FemPH. There was a wonderful one I liked very well called Religard, but Religard's sometimes hard to find. FemPH I find is easier to find.
Great. Okay. Someone wants to know, would it help the painful periods if you use progesterone cream?
Yes. If your problem is low progesterone, and this happens often towards at the time when you begin what's called the perimenopause. Most women begin perimenopausal symptoms about 10 years before menopause, and that is a long, long time to be miserable for 10 years. And the first thing that happens is your corpus luteum just doesn't last as long as it should, or it doesn't function properly, and so you get into an estrogen dominant state where you have more estrogen than you do progesterone. So again, you've got the problem, you've got the estrogen overdeveloping the lining, and you don't have the inhibition of the progesterone to block that overgrowth. And then you don't have the stabilization that the progesterone provides in keeping that corpus luteum active for that about 14-day period of time, so that you don't get your period early. And then also too, there can be things where you don't actually get enough hormones to ovulate, and so then of course you can just skip your cycle. Like I said, then the lining, but the estrogen keeps going and developing an overgrowth of the lining without the progesterone inhibition. So it can really be a problem. So The progesterone creams can be great. There's also a pharmaceutical product called Prometrium that is natural progesterone. I like that a lot. I use a lot of Prometrium. And you start it on about day 15 of your cycle, mimicking what should be happening, which is that's the day you should start having your rise in progesterone, and then taken through to about day 27. Now, if you're sexually active and not using any other kind of birth control, around that 27th day of your cycle, you do want to do a birth control take a pregnancy test, because if you are pregnant, you want to continue the progesterone cream or the natural progesterone pill. You can also go to a pharmacist that specializes in bioidentical hormones, and they can compound hormones for you, estrogen and progesterone, or just progesterone. If you're not having hot flashes and vaginal dryness and the kinds of symptoms that you get as you're losing your estrogen as well, which happens later in this perimenopausal time, really the first thing that happens is you lose your progesterone. So the replenishment of your progesterone can be wonderful for really relieving a lot of those symptoms. It also helps you to sleep better. It affects your mood. Progesterone is a precursor that your body makes testosterone, so it helps to keep your libido good. So progesterone is wonderful. And if you're going to do it, I think it's a lot better to use a natural progesterone than to use a progestin, which is what they have in the birth control pills. I wish they would make a natural birth control pill where they'd use natural estrogen and natural progesterone. I don't know why they don't. I would think somebody should come out with one and they'd make a fortune. That would be effective, because it's just a matter of changing the ratio of hormones. So I don't know why they couldn't come out with one that's natural. But certainly for the postmenopausal period, definitely the natural progesterone cyclic can be good. Some women also will just take the progesterone in either the transdermal cream or one of the pills. They'll use it just as soon as they finish their period. They'll go ahead and start on the progesterone, and that can work as well.
Great. All right. Irma wants to know, can herpes be transmitted by kissing? Herpes simplex type 1 can, if you have a lesion, absolutely can be passed through kissing, and it also can be passed genitally through oral genital intercourse. One of the saddest things I've seen, and I've seen it more times than I could tell you, is women who've made a decision to not be sexually active till they're married, but they go ahead and have oral sex and they end up with genital herpes. I cannot tell you how many times I've seen that happen. In general, herpes type 1, less than 1% of the time are you contagious without symptoms. So once you get that tingling, and usually you're sick and have a fever and feel yucky anyway, because you're more likely to get an outbreak of herpes when you're in a time of stress. So a lot of times you feel that tingling and you know, oh, my lip feels a little swollen, I'm probably getting a herpes. And you are contagious during all of that time. And until the lesion is gone. But you're not contagious asymptomatically with type 1. But now type 2 is different, and you can get herpes type 2 through oral genital contact, and you can have type 2 orally. You can have a blood test to know whether or not you have type 1 or type 2. Or if you have a lesion, you can have it cultured to see whether you have type 1 or type 2. But the weakness in the blood test is it tells you you have it, but it doesn't tell you where. So it doesn't tell you if you have it orally or genitally. But if you don't ever have oral lesions and you have genital lesions, you can pretty much assume that it's genital. But yes, you can get them. The herpes type 2 doesn't seem to have the affinity, doesn't seem to like being in the oral area, but the herpes type 1 has no problem with being genital. It likes it just fine.
You don't need to worry when you have type 1 genitally. You don't have to worry as much about transmission because, like I said, you're usually not contagious unless you're actually symptomatic. But with the type 2, you can be contagious 20% of the time with no symptoms at all. So, very scary.
Yes, indeed. Yes, indeed. All right, Gary says, I thought most contraceptives were 3-day abortives. Is that true?
I don't think that's true. What we're doing is we're simply altering the ratio of hormones so a woman doesn't ovulate. Now, there are certain hormones that women can take that can delay ovulation. That's the purpose of the what they call the morning after pill. It greatly increases the amount of progestin. They give you a huge amount of progestin so that your body will not ovulate. So if you have intercourse, remember you've got the sperm that are going to last in there at least 5, potentially 7, but 5 days. So during that time, maybe you have and maybe you haven't ovulated. Right after you get pregnant anyway, you get a huge surge of progesterone. So all we're doing is giving you a huge surge of progesterone. And so it should not, in theory, cause you to have a miscarriage or to spontaneously abort your baby. It's not the way it's designed to work, and it's not supposed to work that way. It's supposed to simply delay ovulation so that all the sperm have time to die off before ovulation occurs. However, because you have done a big surge of progestin and then it's withdrawn, sometimes if someone is just newly already pregnant from a previous intercourse, for example, and it just newly implanted, sometimes you can cause that lining to be shed, and of course then the pregnancy would be lost. It'd be extremely early in the pregnancy, but it would still be a pregnancy loss, and that's why some people do have a concern about these things as potential for causing an abortion. But it's not the way they're designed to work. It's not the mechanism of action as to how it works. But, you know, with any medication that you take, there can be side effects or things cannot work quite the way they're supposed to. So that's just a decision that every person, you know, needs to make for themselves about how strong they believe about whether or not it's abortive or not. Right. But it's not the intended mechanism of action. But birth control pills themselves actually are not abortive. They're not they don't cause an abortion or anything. They just change the ratio of hormones so that you don't ovulate. And you're not ovulating, so you can't get pregnant.
Right. Okay, Pam wants to know, can we test our pH in the vagina?
You can. You can go and you can get, in fact, most gynecology offices have pH tape, and you can just put it on a little Q-tip, stick it up in the vagina, swab the vagina, and find out what the pH is.
Okay.
You can do that. I've done it. Mm-hmm.
Alrighty. All right.
But usually there's other symptoms when things are abnormal. There's going to be, you know, discharge or odor or something else going on.
Right. All right. About the hormones released during orgasms. What happens with the bonding when someone gives themselves an orgasm? Okay, let me keep going.
Oh, well, I guess you get those same feelings and you get that same hormonal rush, but obviously there's nobody to bond with.
Yeah.
I think it's one of the reasons a lot of people find masturbation so unsatisfying.
Right, it's like firing blanks, isn't it? What happens with the, okay, she continued the question, what happens with the bonding during that process? Is it what creates abnormal sexual appetites, etc.? Is that...
Boy, I'll tell you, that's a question I really never ever even thought about, to tell you the truth.
Yeah,
Because the bonding that happens, I mean, you think about when you have a child and you bond with that baby and you have that emotional connection with that baby, or you're having sex and you're making love and you have that emotional bonding connection with that person. If you're by yourself, then obviously there's no one to connect with.
right.
So now there are people who do this and watch pornography, and yes, they are abnormally bonding with the people that they're seeing on the screen, and that's one of the reasons that pornography is so incredibly addicting.
Right, right. The person who asked that question says thank you. So I think you've answered it satisfactorily, or better.
Oh, good.
Okay.
That was a hard one.
Yeah, it's a new one, isn't it? New one.
Yes, it was.
All right. Okay. I think there's one more, and this is the lady who asked about getting herpes from kissing. And she says, after you answered her question, she said, I'm always paranoid about catching something sexually. I just wanted to know if I now need to be paranoid about even kissing someone.
I wouldn't, unless that person has a cold sore. Then I wouldn't kiss them.
Or if the person has bad teeth or something. Huh?
Yeah. Yeah, you might get some bacteria, but it probably wouldn't be herpes. I mean, herpes is a virus. Most of us have it. At least statistically says that 75 to 85% of us already have herpes type 1. Most of us got it from a relative who kissed us when we were a child. So yes, we have it, and many people, it's extremely rare for people to have herpes type 1 outbreaks. The average person has one outbreak a year, and while it can be devastating for a newborn who has very limited amount of limited immune system at that time, and so definitely if you have a herpes on your lip, do not kiss any newborns, because you can give herpes to the newborn. And they're very vulnerable, but by the time we're, older, 2 or 3 years old, we have a very intact immune system, and even if we get it, most of the time it doesn't cause much trouble. Almost everyone has had herpes, and almost everyone has had a cold sore at some point in their life. So, and like I say, it's usually type 1, and it's not that big of a deal. It's just something you endure for a couple of days and it goes away, and it's not a big deal. Herpes in the genital area, however, is a totally different thing, because now you have a place where, whether it's type 1 or type 2, if you have a herpes outbreak at the time of birth, your baby can pick that up coming through the birth canal. It's not 100% that it's going to happen, but it can happen. And of course, if your baby gets herpes right as a newborn, it's really a devastating illness. I mean, they can even die from it. So it can be very scary to have it in the genital area, and that's why if you have an outbreak around the time of your delivery, most of the time the doctor will do a C-section. To keep the baby away from coming through the birth canal and coming where it could come in contact with the virus in the genital area. It's one of the most common reasons women get C-sections, that aren't having. I don't want you to think that, oh, so and so just went in and had a C-section, she must have herpes. But if women have a herpes around the time of their delivery, they will usually go ahead and do a C-section.
Right.
To reduce that risk.
That'd be much.
But as far as being paranoid about kissing anybody, I wouldn't be paranoid about kissing anybody. No, I wouldn't.
Right. Right. Okay, well, that seems to have been the last question, and I just took it from you briefly, Vicki, just to let people know that for most of our presentations, folks, you can actually, after the presentation or the webinar, you can go to our site and actually click on the banners. And if there are questions that were not covered or you thought about a new one, yes, you can contact Vicki or our presenters directly. Usually they give you their emails, but you can also, just by going to our website and the homepage, clicking on the banners, and you can actually leave your comments and questions. And if you think she did a wonderful job, you can also write it there as well. And that way you get to see what other people have written as well. And you can see, you can set a long thread going, and that's really helps as well. For other people visiting the site and seeing that, seeing the kind of questions and comments that have followed the presentation. I think that's a powerful thing to keep going. Also, just wanted to let you know we are doing a promotion for memberships. And remember, with memberships, you can have access to our close to 200, I think it's even past that now, but over 200 webinars where you can watch, like Vicki's. We've been a little slow putting them up, but we've now gotten help, so that's going to be a lot. It's going to be a lot faster to see the turnaround, to have the presentations actually on the site available for memberships or for members. And you can watch the entire presentations online. So that's a tremendous resource, even if I say so myself. And what was that, Vicki?
I plan to join because you've got a great special going on. I absolutely am going to sign up.
Oh, great, thank you.
Because I watch a lot of the webinars anyway, and I need to go ahead and sign up so that I can get them and access them whenever I want.
Right. That always helps. And we've just gotten lots of great favor with now. We are now being called upon by other healthcare professionals who see the work that we're doing, and they want to join in, and they're sending us their list of presentations that they would like to do. So well, things are becoming going to get a lot busier next year for sure. Okay, someone's saying, Montana is saying, ask Vicki to do a webinar on perimenopause and natural health and remedies. So
I'd love to.
You would?
Yeah, sure.
Oh, well, great. Well, Vicki, you know that anytime you're ready to do a presentation, we will set it up for you. So let's talk about that. That'll be great.
You know, I did the toxin clear pregnancy one too, where we talked about toxins and how to detoxify in pregnancy, and that was really good. Very, very informative. And if Montana, if you haven't seen that yet, you need to get it. It's actually in DVD form, I believe. I think. So you can actually get a DVD of that as well. Vicki, we need to make a series of your DVDs or package. Okay. I know. Just got to find the time to do it.
Yeah, it's really involving, isn't it? Just preparing for presentations.
I would really appreciate if people would tell me if they thought my slides were clear and if they found them helpful in understanding, because I know it can be a difficult concept.
Right. So folks, please let her know, okay? Feedback is vital, especially when we're educating people that we cannot see, you know. So we would like you to send in feedback so we can know how to improve. And that's what Vicki is asking for. All right, let me see. There's one more question for. Someone says, yes, pictures would be good too. Well, I wonder what she means. Okay, pictures would be good on her slides. Are you talking about the perimenopause presentation? Because I think she had a lot of slides, a lot of pictures on her slides tonight, for sure. All right, sending that last reply, Montana, so we know what you're talking about. Okay, I don't see anything yet. She's probably walked away from the computer. All right. Okay, she said more on this last one, this presentation. So apparently she thinks you should have had more pictures on this presentation, Vicki.
Okay, I'll work on it.
Okay. Well, then again, we couldn't do the one with the video where we would actually see you drawing stuff on the board, and that didn't work because the connection was not good enough for that, right?
Actually, we figured out the problem. The problem is that this is a medical office, and we have a firewall up that won't allow any pictures to go out of this office. So that people's privacy is not ever going to be compromised with video.
Oh.
That's why we couldn't do it on video from the office where I work.
Oh.
Isn't that nice to know that you have that protection? I was really glad to hear that.
Right. Right.
So I have to find another computer, and then we can do it where I can draw this, because I think it's a lot easier to understand when I draw it.
Right, but you did do I think you did a really good job explaining it for sure.
Good.
Thank you again. All right. Well, we're going to wrap it up. This actually, I think, is our last presentation for the year 2010. So, Vicki, you helped us wrap it up.
Woohoo! That's
Woohoo!
good. Happy New Year to everybody, and God bless you. Have a wonderful, wonderful Christmas.
Thank you, and you as well.
And holiday, whatever holiday you celebrate.
Right.
But Christmas for me.
That's right. Lots coming up. All righty. Thank you again, and have a great night. God bless everyone. Bye.
Bye-bye.